Hey, thanks, Elizabeth. Thanks for everyone for joining. I'm Justin Gomez with Wake Forest Baptist Health. I have the honor for introducing Dr. Satterwhite today, and it's been great to work with him and his team the last couple of years on all of their exciting projects and helping local businesses with their healthcare solutions. I first met Dr. Satterwhite. I don't know if he remembers this, many years ago when my first son was born, and I was at his pediatrician's office, making sure Samuel was doing well. So great to get to work with him now. A little bit about Dr. Satterwhite. He joined Wake Forest Baptist Health in 2015 as the medical center's first chief health and wellness officer. So he's responsible for the internal wellness department, so helping take care of me and 19,000 of my colleagues, as well as the Best Health for Business area, which consists of corporate health, executive health, and occupational medicine. He and his team develop value-based, customized healthcare solutions for self-funded employers. More recently, during this COVID-19 era, he's led the team that developed the face masks that were used in the Mask the City initiative in April that distributed over 390 masks to all the residents of Winston-Salem. That includes free masks for over 75,000 people living below the poverty line. So that was a great initiative. More recently, he's also led the development of a COVID-19 symptom survey tool for employers to use in getting their employees safely back to work. The tool is known as SneeSafe. Prior to this role, Dr. Satterwhite had 16 years of clinical experience as a pediatrician and a physician administrator, which I mentioned a minute ago. And Dr. Satterwhite received his bachelor's degree from Davidson College, his law degree from UNC Chapel Hill, and then went on to get his medical degree later from Wake Forest School of Medicine. So I'm glad you traded in the Carolina blue for black and gold, Dr. Satterwhite.
Thank you very much. All right, I'm so glad you guys are here, everybody. There are 30 to 50 of you out there. I'm not sure what the final count is, but I appreciate your being here. We're going to be fine having questions come through the chat line. Elizabeth is actually going to essentially assemble them and collate them. And so we'll work in that fashion on the questions and then hit them all really at the end. The other thing is, for me as a presenter, it is always nice if some of you will keep your video camera on. Otherwise, I feel like I'm practicing in my garage, and which is okay if that's the way you want it to go. So I'm going to take over the screen for a moment, and we are going to do this little slideshow. And essentially, for roughly 30 minutes, I'm actually going to go through these and lay out a framework for you. But I'm going to begin with a simple question, which I want each of you to ponder. Why bother? Why do we bother taking an hour out of the day? Why are we bothering on and on with COVID-19? Just ponder that for a second. Now, for me, part of the answer to that question in my mind relates to how long do you think this is going to last? So if this were a multiple choice test and those were the questions and you had to commit, what would you say? Right? Does anybody want to commit in the chat? In the chat box? 18 months, 6, 24, 6, 24. Yeah, it's a fascinating question. How you answer that can depend a lot on what you actually want to do. And so it's very tricky on a lot of this. All right, I'm getting, people are requesting to annotate the shared content. I actually don't know what that means. So I'm going to decline as that comes out, and we'll see what happens. All right, so let's get rolling. These are basically, let me tell my projector to come alive. These are basically the 5 keys to survival that we're going to talk about. And we're going to hit them each pretty quickly, but the goal is for you to leave with a little bit of a nugget from each category. So first, we're going to talk about a visible culture of safety. All of us know every single business enterprise has some kind of culture of safety that they've always had. Decrease injuries, in the hospital, not get stuck with needles. I mean, it doesn't really matter, right? But now what's happened with COVID-19 is that safety, and particularly the cleanliness, has to be pushed to the front. It has to be extraordinarily visible. So I chose this picture of the grocery cart scene, the shopping cart scene, because early on, as COVID hit, I can remember going into one of the big box stores, coming up to the big stack of carts, and I didn't know if they'd been cleaned or not. They were in the place usually where you get the carts, but I noticed the person with the orange vest on and the cleaning stuff was kind of off to the side looking at her phone. And I was like, so am I supposed to take this over there? There was no sign. I had no idea what to do, right? And many places aren't great at that. Now, I would say since then, places have gotten better. I happened to steal this photo from Lowe's, and this is part of their safety promise. So this visible culture of safety. But it is key to me, and the stores that I like to go in the most are the ones that have a person there when I walk in the grocery store or the big box store, and they literally are cleaning the handle of the cart and push it over to me and go, great, here's your clean cart, thank you. So this sense of visible culture of safety. And of course now, culture of safety has been expanded to include things like gloves and a mask and plexiglass. And we all feel better if that's there. And all would include the employees. So a couple of months ago, actually, when I gave one of the first talks on this topic, I polled the audience and said, who are you most concerned about? Your employees understanding that you've created a culture of safety, or your customers? And everyone said employees. That was their biggest concern and number one thing. Now, I saw this great visible culture of safety actually for my 36th wedding anniversary. So that hit in July. And because of COVID, many of our children and spouses and grandchildren ended up at our house for one reason or another for a pretty long stretch. And so they were still there during this time. And we said, man, it's our 36th wedding anniversary. We've got to go somewhere. So what do? We said, we're going to go stay at a hotel on Haynes Mall Boulevard for 24 hours. And so that's what we did. And the place we went, interestingly enough, was actually a Home 2 Suites by Hilton. I'd never stayed there. And one of the things that struck me right off is they actually put this seal on the door indicating that it's been cleaned and that no one has been there since they cleaned it. And I thought that was fascinating. Now, I will say, several weeks ago, we actually drove down to Austin, Texas, where our fourth and final child was launching into her, full-time job. And we stayed in a couple of hotels on the way there and on the way back. These were the only rooms, the only hotel chain that actually did this. None of the others did. It was fascinating. We thought, wow, I hope no one's been in here since it's been cleaned. The other thing they did at this Home 2 Suites was they actually had posted on the bathroom mirror all the things they cleaned and have them labeled throughout the room. And even the TV remote had this kind of plastic wrapper around it indicating it had been cleaned. And I will say, I felt better about staying there than in any other hotel we stayed in. I'll also confess we wiped it down as soon as we got there. But at any rate, it was impressive, this visible culture of safety. So the thing for you to think about is, do you have one of those, right? Are you doing that? Is it clear to everyone who works there and comes in, these people are doing it right? Right? They are doing everything that we know how to do to help. Now, let's look at symptom surveillance. All right, the idea behind symptom surveillance is this. It's a bit analogous to the forest rangers. And I don't know if they still do this. They get in the really tall tower, high above the tree lines, and they basically stand there and look for smoke. And if there's smoke, they go investigate. Maybe a campfire, might be the beginnings of a forest fire after a lightning strike, who knows? But that is what they're doing. And so symptom surveillance tools have that same purpose as the forest fire tower watchers. The idea is to say, gosh, are we seeing increased, we would call it signal sourcing, from something that needs to be investigated? All right, that's the best, highest use of a symptom surveillance tool. Now, I will tell you candidly, when all this got going and we were helping employers, a lot of that was on site with our own health personnel asking these questions, and it was expensive and hard to staff, and we knew that wasn't going to last. We looked at the landscape of survey tools out there, and we didn't really see anything we liked. It wasn't drilled down in the way we felt like our own corporate clients were using it and wanted to use it. And so, to make a long story short, we basically invented our own. And it starts like some of them do, but not all. So here you actually do register and create an account. Some of the other ones, like a WebMD or CDC, are great in the moment to say, if you're sitting at home, do you think you have COVID or not? But in an employer context, you actually need to know, for each person, are they okay? They do the survey, internal logic says you're cleared, or you get the stop sign. And if you get the stop sign, that means you need follow-up. And at the same time, the employers or a school can actually see a real-time dashboard to know, is Bill Satterwhite showing up for his shift today? Which is actually what they care about right now. So it's a very workplace-centered tool. And so here are a couple of screenshots, only so you can have another visual. One of the survey on the left. The Demon Deacon is here in the middle because actually Wake Forest is using it for their faculty and staff, and then also for their students. And this particular tool is flexible enough so you can subdivide that whole population into groups and subgroups. So the faculty and staff are one group that gets to go through it, and if they get flagged, they actually end up going to employee health, initially by telephone, and then students go to student health. And Wake Forest has gotten real savvy too. They've realized, we can break this down even more. So they've created subgroups, like the football team is a group, the baseball team is a group, the soccer team is a group. Because if you look at illness transmission, mostly it happens between people in groups, right? If you live alone on an island, you will not get anything and you will not give anything. And then the third screen just shows how we have an easy button. In this case, click to call a nurse. And so for a student, that goes straight to student health. For a worker, that goes to employer health. But that could go to anybody. So some companies that are using it, it goes to their HR director. Some, it goes to an on-site clinic they have staffed by a third party. I mean, it really just could be anything. But part of the purpose is to say, are we seeing increased signal sourcing coming from somewhere? And then can we go investigate? And so in some of the businesses that we have worked with that have multiple locations, 10, 20, 30 locations, we've broken those down into subgroups so that we can look at that data in real time coming in. And often they will start having several days of a sudden spike in symptoms. And then 3 or 4 days later, somebody's positive with COVID. And so it's very helpful to say, wow, we're having more action there. We need to clean more thoroughly. We need to work from home more quickly. We need to make sure everyone's wearing masks or doing something that's going to alter the current trajectory of what's happening. So maybe we don't have to close or shut down. So it's a helpful tool. And again, there are other ones out there. None that we have seen so far actually can really direct a person to an immediate response. A number either link you to telemedicine or something else. And we just felt like, no, the worker needs to know, can I go to work and get paid? The employer needs to know, are you showing up or not? And that's got to be really in real time. So people actually get sent a link even before work starts. They go straight to their survey and they can do it. Not an app, web-based, but that's a lot about that. But I think on some level, symptom survey tools are helpful. It really makes people commit. I can have a headache for a lot of reasons, only one of which is COVID-19, right? But it's still worth doing. So I would think about that as something in your toolkit about how do you make your place safe. Very helpful. The next thing, mask wearing. All right, we're going to talk about masks because masks are in the news for sure. And I want to give you some of the background on it and help frame it up so you can see why it's become such an important thing. But the first thing we're going to do is we're not going to talk about medicine or science or masks. We're actually going to talk about constitutional law. So as Justin said, I went to law school, was a lawyer for a while, and I'm going to take you through a little baby version of Constitutional Law 101. All right, here's what you need to know. And I'm telling you this because a lot of people are saying, hey, you're infringing upon my rights as a citizen if, you business are trying to make me wear a mask to come in. So here's the thing I want you to take home. Constitutional rights like free speech, freedom of assembly, etc., those only exist between an individual and the government. All right, individual and the government. Not between two individuals, not between an individual and a business, not between two businesses. Okay, so this idea of I have a First Amendment right to free speech, yeah, you do vis-a-vis the government, right? What can the government come in and say you can or cannot say? That doesn't exist for a business. So if I have rules in my coffee shop about what you're allowed to say and not say, and you violate those rules, I can kick you out. That is not a violation of your rights. You may not like it, but it's not a violation of your rights to do that. Same for what you might have to wear, right? So everyone's familiar with the long-standing signs of, no shirt, no shoes, no service, right? And so to say, okay, if you don't have a mask, you don't get service, that's not a constitutional right violation, right? You're free as an individual consumer to go get coffee somewhere else. And I may say, these are the rules by which my business is going to play. Now, there are a few exceptions to that. I can't exclude you because of race, age, gender, etc. But we're not going down that path. All right, so that is Con Law 101 for those of you who haven't had the pleasure of going to law school. Now, let's dive a little bit deeper into masks. Why did we do Mask the City? Why do we think it's so important? Well, the reason is they're incredibly an inexpensive, effective way to decrease the sharing of any kind of infection, but in this case, for COVID. So here's a copy just of a table from an article called The Lancet. It's out of Europe, and it's one of the kind of like the New England Journal of Medicine. So it's a big time thing. And what you'll see at the very bottom, and I ended up retyping it because it's a little bit hard to see on the copy, is the chance of viral transmission. If I've got it, an illness, and you are wearing a mask, the ability for me to give it to you is extraordinarily low, about 3%. Whereas if nobody's got a mask, it's about 17%. So it is an incredibly effective, easy way to just decrease the rate of transmission among people. And honestly, it's true whether it's flu, COVID, or something else. In this case, because no one has any natural immunity, it matters a lot. So that's a little bit, one glimpse of some of the science behind it. They analyzed a whole lot of different studies because actually mask effectiveness has been studied for a long, long time, mostly in the context of flu, H1N1, that sort of thing. Now, I will tell you this, studies with masks are hard to do, and the reason is a lot of them would be unethical. So let's say I have COVID-19, and I'm, highly infectious in the moment. No one is going to approve a study where I sit down and breathe in the face of 100 people for 30 minutes, one-on-one, and then sit down and breathe in the face of 100 people wearing masks for 30 minutes each. No one's going to approve that, right? You can't do that kind of study. So these are more sort of retrospective looks at what are context or population-based, and figuring that out. I will answer this about the N95 that somebody popped up. It's just basic masks right here. That's what most of the studies are all about. There definitely is a whole sort of cohort of studies that take place in the hospital. How effective are masks? This is any kind of mask. And I'll show you why it works, okay? This is going to get a little bit deep science, statistical stuff, but we're going to go for it. I've done a background check on all of you. I know you're extraordinarily brilliant. So here's what we're going to do. This is this graph, really mathematical modeling. I'm going to start at the left-hand side. The y-axis is the percent of people wearing a mask within a given population. All right. The x-axis down at the bottom is how well does a particular mask block those germs from coming or going. All right. And of course, the goal is, well, I don't want to skip too far ahead. I'll tell you what the very top stuff, RO, means. So if you look at the bottom left corner, RO are just the initials for essentially the transmission rate for any given infection. So if I've got the infection, how many people am I going to give it to? All right, they're going to get sick. They're going to contract the illness. And so for COVID-19, right now, it's about 2.4. All right, so that means if I've got it, I'm going to infect 2.4 people. The 2.5 people that I infect are now going to infect 2.5 more each, and then 2.5 more each, and 2.5 more each. And so you get a bit of a compounding effect. Now, what does that mean? Well, if it's 2.4, and I put the factor there kind of right at the graph right there for a particular reason, it's going to show you that if people were wearing a mask, it was 50% effective, but only 15% of them were wearing it. If 100 people had the virus, 30 days later, you have 31,000, right? So if you're an investment advisor, this is the kind of investment you want to make. here's $100. 30 days later, I have 31,000, right? And so it shows the incredible replication and transmission factor that happens in this kind of a context where your RO is 2.4. All right. And we have an okay mask, but hardly anybody's wearing it. Now, here's the fascinating thing. If you're able to bump those numbers a little bit higher, the percent of people wearing it and the mask itself, you can get to an RO of 1.35. And so 30 days later, we've only gone from 100 people infected to 584. All right. And so this slide right here shows you why when everyone shows up, for the wedding, the funeral, the graduation party, they're all together for several hours. Let's pretend 100 of them have COVID and maybe they don't know it yet. And then they all leave. 31,000 people are going to end up sick if nobody is doing anything else other than living life as usual pre-COVID. And we've seen some of that happen where states that open quickly, they're like, screw it, we're not fooling around with anything, do whatever you want. And boom, all of a sudden it's exploded. And that's happened in some other countries too. I mean, India basically has doubled the number of cases they have in the last 30 days. Wow. Well, this is actually why. All right. So if you can wear a mask that's halfway decent and more than half the people wear it, you'll really slow the spread of that illness. Now, the goal is to get it below 1. If we can get it below 1, it basically gets snuffed out. It doesn't mean the virus is gone, but it does mean that it's not going to continue to get transmitted over and over and over in a fast way. All right. And I will say that, if we can even just get 80% of the people in a given geography to wear a mask that, again, is halfway decent, so it doesn't have to be an N95, it could be kind of poor. If everyone's wearing them, you drive the transmission rate way, way down. And so it becomes effective for a population, right? Very effective for a population. And so you see this actually in Germany, where they've got a much more centralized healthcare system so they can sort of plot things out. And this was in one of their cities where they instituted a mask mandate. The dotted line is projected rise in cases, and the flat line is what happened after they instituted that. Basically, it leveled off, right? It was probably 1. I infect 1 person. We're just flat. We're not going down, but we're not going up. So highly effective on a population level. And I will say that this is part of why we did mask the city, even though we were way ahead of the curve. So I was pretty proud of our city for that. This idea of, I think the most economical, fastest way to get everyone back to work, back to school, doing their stuff is to get everyone to wear a mask. And as we've seen in the previous graphs, it works best if everyone wears it. So if only 20% of the people are wearing awesome masks, you'll still have tons of illness going around. But if we can get everyone to wear something, then it's going to help us get back to life much, much more quickly. And so Winston-Salem's actually done a great job. I mean, more or less, things are fairly flat in our city. Now, unfortunately, we weren't able to mask the whole county and the whole region. We were ahead of the state governor's order, that everyone ought to wear a mask. But it shows you how effective it is, right? And I think in the long run, that's going to pay off beautifully for us. I know when I met with some of the initial business leaders and the mayor, I said, look, I think this is the fastest, easiest path. It's the only thing I can think of that we can do. And of course, we ended up manufacturing them because there was no other place to get them, right? You couldn't buy them anywhere. Now you can get a lot of them. I'm happy about that. But this was a phenomenal feat for our city, and a lot of you had a big role in that. Now, let's jump to infectious disease consultations. So one of the keys to surviving really this whole thing is recognizing that as you lead your business through, you're going to encounter situations that don't fit neatly within CDC guidelines or recommended course of action. And we've seen that a lot. Now we get a lot of those calls, and it's important, I would say, to have some sort of healthcare person on speed dial to get to when you have oddball stuff come up. So we have had people, tested positive, quarantined, and then they were, going to go back to work once they had a 2 negative test, because that was the rule at one point in time. And so they had 1 negative, they're all happy. Then the next one's positive. So then they quarantine some more, then they go back and they have a negative, then they have a positive. Next thing you know, they've been out of work without symptoms for like 50 days. Right? And you're like, okay, this is ridiculous. Our tools are not that precise. Okay. And so what are we going to do? And so what we have found very helpful is if we have engaged with businesses, we have tended to say, all right, we're going to write in a couple hours of infectious disease consultation because stuff's going to happen. If you don't have anybody else to call, you need somebody to call. Things are going to happen that don't fit well within the nice little guidelines. So that's a bit of a tip. It comes in two areas. One is infection control. A lot of people wonder, well, what is infection control besides just keeping germs down? Well, I'll let you in on a little secret. All hospitals and health systems have an infection control department. And that sounds a little creepy, but I'll tell you why. Because a hospital is one of the few places where you go find people infected with all the different germs and you put them in one building, right? And so what does that mean? Oh boy, we got to be super careful about how we clean and about how we keep those germs from going from one person to the next to the next. So there are whole departments, lots of science around what kills what, how you clean everything. Now a lot of that is getting exported to the non-medical workplace, which is one of the things that makes it so hard. People are like, we're not doctors, we're not scientists, we're not healthcare people. What's the deal? So having folks to rely on is extraordinarily helpful. Now, I will say a lot of industry has stepped in, a lot of the cleaning industries, a lot of the industry associations. So for the most part, that's way further along down the path and good than it was, 3 or 4 months ago. And then I mentioned the infectious disease consultation. Now, let's talk about vaccines. All right. They continue to be in the news, as you know, and it's a bit of whiplash between, they're going to arrive by November 3rd. They're never coming. Nobody knows what to think. So I'm going to tell you what I think just the facts are and sort of give you the landscape on vaccines. So this is another science lesson. So the first thing you need to know, 4 years is the fastest a vaccine has ever been developed to date from conception to distribution. 4 years. Now that was a mumps vaccine. That's been a while. You may say, well, we are way better than we were then. Okay, awesome. That's great. Here's the thing to think about. Even if we're smarter, even if we have more scientific tools and machinery, all the more money, doing it in 2 years would be stunningly fast because it takes a while. And we'll go into some of the reasons it takes a while in a sec. I'm going to talk about effectiveness next. So one of the big unknowns is how effective is the vaccine going to be, right? So right now they're in the phases of saying, hey, we gave it to some people, really nothing too bad happened to them from a side effect perspective, and they got an antibody response. Okay, well, that's nice. That doesn't mean those antibodies are active and working. That doesn't mean they'll last a long time. It just means you got a response. So the question right now is, how effective is the vaccine going to be? And all we have to do is look to what's out there to get some sense of it. So polio was an astoundingly effective vaccine. There used to be 250, 300,000 cases of polio every year in the US, mostly among children. Vaccine came out in year 1, it dropped to 5,000. And now it's essentially negligible. If anyone can get the vaccine, you could jump in a swimming pool full of polio and you will not get out of there with polio. It is so incredibly effective. And there's some other ones like that too. Now, flu's in the middle, right? I mean, the reason we get it every year is because the immunity wanes. It's not always a bullseye shot with how to do it because the virus mutates a lot. And so, it's kind of a middle of the road, helpful, but gosh, not like polio. And then you have HIV. 30 years later, billions of dollars later, no one has developed a successful vaccine. Now, there are lots of treatments for it that sort of ameliorate it, calm it down, keep it from killing people fairly rapidly, which it did originally, but no vaccine. So, where is this going to land, right? Lots of money being thrown on it, way more than anything else in this time period. But that's a big question mark. And then you have issues of distribution. If you're in supply chain, you know how hard that is, right? We got 220 countries. We got 7.8 billion people. And by the way, we already talked about how, for masks to work, everyone's got to get it. For vaccines to work, everyone's got to get it if you really want to keep it down, right? So smallpox, World Health Organization had this incredible push to totally eliminate smallpox, but you got to basically give it to everyone in a condensed period of time. Otherwise, it keeps happening, right? So think about a forest fire. It's helpful to put out the forest fire here, but if you can't also go put it out here and here and here, at some point it's coming back, right? It's going to come back. So you want to do everyone in a short period of time. Then you have issues of priorities. Rich people first, older adults because they might need it more, countries, lots of issues around there. And it's estimated right now it would take 10 million workers nonstop to give everyone a vaccine. And who knows, will we need one? Will we need two? Lots of questions. And then we just have the social question, will people take it? You know, the last 10 to 20 years, there's been a lot of denigration of science. They're wrong, they're wrong, they're wrong. And scientists are wrong plenty, and doctors are wrong plenty. But they're also right with the big bulk of things, way more than they're wrong. And so science has been very denigrated. And so now we're going to turn to people and say, hey, science has figured out this is a great way to help you. A lot of people are very suspicious. Interestingly enough, people who believe in science are also suspicious. Hadn't been tested well enough. We haven't given it enough time. I'm not doing that. And so it's a real toss-up right now. You know, would 50% of the people refuse? And if they refuse, are we going to make it a law? Are we going to have vaccine police? I mean, it's lots of questions. And then the last one really is, how long will it last? Again, flu vaccine, you get it over and over. Sorry, I was distracted by someone who asked, why the rich people first? I'm not saying the rich people first. I'm just raising the question of what's going to be the prioritization, right? Most vaccines have a small population they're going after, right? So shingles vaccine, that's easy. That's old adults, right? Polio, MMR, that's easy. That's little kids. And so here we've got something where it's everybody. All of a sudden, everyone, everywhere. And so somebody's got to sort out, you know, they're not going to be all of a sudden 7.8 billion doses available instantly. It's not going to happen. So where do you start is really the question. And how long will the vaccine last? All right, so let's stop right there. Happy to be distracted. It means somebody's out there listening. You know, I'm practicing my garage if nobody says anything. These are some of the things that I just wanted to put on there in the event anyone wanted follow-up, so we don't have to leave it there. I'll actually stop sharing here. There we go. And maybe you all can come back to life because I love seeing faces other than my own. And we'll see, Elizabeth, maybe you can kind of collate questions and fire away.
Sure. Well, most of the questions have been submitted while you were talking, so thank you, Bill. I'd love for you to talk a little bit more about what you're referring to as a halfway decent mask and kind of what that means. If I'm needing to put a halfway decent mask on my employees, what kind of mask am I putting on them?
Yeah, great question. So there are two ways I would address that. One is, you know, when people are like, okay, is this mask any good? I always want to go, compared to what? All right. Compared to what is where I start. Compared to no mask, absolutely. Right? Almost anything, and the CDC has shown that over and over, the World Health Organization has shown that over and over. Almost anything over your face, if everyone did it, would be better than nothing over anyone's face. So on some level, anything is better than nothing. Now, is any mask as good as an N95? No way, not a chance. The N95 is a little bit of an engineering marvel. All right, because it is able to balance out things that are inconsistent. Now, what I mean by that is this. So to some extent, we think about how effective is a mask at blocking the particles from either going in or out of the mask, right? This sense of sort of filtration and barrier. Okay, but that works against a couple other things. So the tighter the filtration barrier, the harder it is to breathe through. All right, a plastic bag is a great barrier. It's a really, really good barrier, but it's impossible to wear, right? And so you've got to balance out this sense of how easy is it to breathe through, how hard is it to breathe through. And roughly speaking, the tighter the weave, the more layers, the harder it is to breathe through, right? It's pretty easy. And versus how hard is it, how comfortable is it? So I can wear something that's hard to breathe through for a short period of time. I actually can't do it for a long period of time. It's just too hard. The other thing you have to know that works in the exact opposite direction of barrier and filtration is how much does the mask leak around the edges? So most of the time, most people's masks don't fit that well. And the barrier, if they've got a lot of layers, is pretty substantial, which means they can't exhale or inhale very well. So mostly people are actually breathing around the sides of the mask, which means they're breathing unfiltered air, okay, which defeats the whole purpose of it, right? And so to me, my sort of place is, can we find masks that are middle of the road or better in terms of their ability to stop particles? Because usually that means that people can wear it for an extended period of time, and it's going to be effective, especially if you're wearing one and I'm wearing one. Now we keep cutting in half our ability to give or receive. And then can we have masks that fit reasonably well around here without a lot of leaking? And that's hard. And that's why the N95 is really an engineering marvel, because you're able to wear one of those that seals so you don't get any air leaks, but at the same time breathe through it. And they've been able to accomplish that a lot with electrostatic charges within the layers. It's really pretty phenomenal, because otherwise you can't breathe. And so what I would say is any kind of mask is better than nothing. You are going to have to balance out how easy is it to breathe versus not. And I guess the other thing I would say too is surgical masks have been, promoted as the thing, mostly because they've been there. Surgical masks were designed to keep the surgeon from coughing or drooling or spitting, into your body while operating. It was designed to stop liquid, not aerosolized particles. So it by design leaks. And so it's a toughie on whether that's, better than some of these others. My own opinion is either a tight weave or 2 layers of something. If it fits well around, so it's not zero leaks, nobody's going to get to that. If it fits well around, then you're probably good. You're sort of as good as it's going to get. And then I would just, roll on in terms of the social distancing and the hand washing. And again, if everyone's doing it, the odds of getting something are extraordinarily low. Never zero, but low. That was a very long answer. I apologize. Is there time for a second?
Thank you, Bill.
Is there time for a second one?
Well, what about hand sanitizers? There's been a lot in the news about these are on recall and this, that, and how do I know I'm getting a quality hand sanitizer that's actually going to work for my staff?
Ooh, boy. So I'm going to admit ignorance on that. I'm not sure how and in fact, because I don't know where it's all coming from. That's the thing. I would say anything with high alcohol content seems to dry out the germs and kill them. I mean, that's why some of these distilleries started making hand sanitizer. They're like, hey, we got 90 proof, no problem, right? And so, that's really the key thing. The other thing is, of course, just pure hand washing, in part because literally the moving water picks up the germs and they float away. And so it's highly effective. I'm not good enough to know, this brand of hand sanitizer versus that one.
But is there an alcohol content minimum or anything? Like we've heard about 70% and 90% and things like that. Do you know anything?
I don't know that either.
Okay. Well, we can put together some information from our infectious disease team. Excellent.
That's why you have them on standby.
Yes.
EC says 60%. There you go. I mean, the key thing is in part breaking down or killing germs, but it's mostly about the drying with this infection. They don't survive if they get dried out. And so that is mostly what alcohol does. That's why it makes your hands crack up after a while. Right?
Yes, absolutely. Anything else, guys? I know we've had a few more questions submitted. We've asked a few of those. Okay. Well, I want to thank Bill and everyone for their time today. We will be sending a follow-up email, so if you have additional questions for Dr. Bill, please feel free to respond with those. We will send them on to him and connect you to him. So thank you guys so much, and I hope you have a great rest of your day. Oh, I'm so sorry. Hold on one second. We have Bill. I need you to pick a number between 1 and 20 for me, because we have a gift card to give out.
It's got to be lucky 13.
13. And the lucky winner is John Martini. I'm going to unmute you, John. Congratulations. And we will get in touch, and Jason in touch with you to get you those gift cards. So thank you guys again for coming.
All right. Thank you all. Have a great day.